One set of studies presented by our academic collaborators looking at the impact of nVNS on cortical spreading depression, which is a known mechanism of action in migraine, and some really interesting observations from that study. So for one, we showed that there's actually a dose effect of the VNS dose amplitude with regard to its ability to suppress cortical spreading depression, and the dosing regimen, which is what we use in the clinic, was also the best regimen of 2 stimulations at 2 minutes. Two 2-minute stimulations produced the most potent effect in the animal model, and then looking at more of the kind of how is the signal transmitted by the VNS actually suppressing the CSD. Those studies showed that it is a stimulation of the afferent vagal fibers that end up in the NTS, which is a brainstem nucleus, and then from there through serotonin and norepinephrine mediated pathways are able to suppress these CSDs. CSDs are particularly important in migraine with aura, and as a coincidence, we recently had a case report published of a patient with aura who was successfully able to treat aura with gammaCore. So in our clinical trials, whether subjects have aura, migraine with aura, migraine without aura, they treat at the onset of pain, not at the onset of aura. So this patient had very characteristic aura, was able to, with using VNS, reduce the duration of the aura, reduce the number of times that aura led to a migraine and the intensity of the subsequent migraine. So that's a case compared to her standard of care medication, which was a triptan. These mechanistic data are sort of timely as we're seeing these kind of clinical data emerge. And we know from our studies that VNS appears to be particularly potent in migraine patients with aura. A separate set of studies presented by Paul Durham looked at VNS modulation of pain in a chronic migraine model and an episodic migraine model. And in the chronic migraine model, nVNS was as potent as opiates, and in the episodic migraine model was similarly potent to sumatriptan, but he showed mechanistically the pain suppression works through different pathways, which is supportive of the idea that if using nVNS on top of a triptan, if the patient doesn't have adequate response to a triptan, since they're modulating pain through slightly different pathways, you could get an additive effect. And on the clinical side, at this conference we have presented some data from a patient registry of in-cluster headache. And a small case series of, I think, 14 patients with vestibular migraine was reported here as well, and presented a study design for one of our future areas, which is another one of your questions, where we'll be doing a study in post-traumatic brain injury headache, and the rationale and study design were presented here as well. The use in patients with aura is interesting because now we have a mechanistic tie-in. We now have some, a case report, but we'll hopefully soon have others where the device is active on aura as opposed to the migraine headache itself. And as I mentioned in our clinical work previously, the prior clinical studies, we have seen that aura patients seem to respond particularly well. So that's an interesting subgroup, and it's about 25% of migraine patients have aura. I think that's an area that I found particularly interesting, and I think we'd like to do further clinical exploration there, see if there are additional benefits we can bring to those patients.